Today we'll be reviewing the increased intracranial pressure and hemorrhages. So before I delve into talking about the management, I will take a look at the anatomical structures of the meninges. So the first layer that covers the brain first layer that covers the brain is pia mater. So pia mater, this layer right here, is translated as a soft matter, and it covers the gray and white matter of the brain. The next layer is arachnoid matter. It has these projections that extend into the pia mater. The next layer is dura mater. These both layers are dura mater, but one is the inner and the other one is outer. But both of them are dura maters. Then we have the skull and the scalp. And on this diagram, we have the same structure. So we got the gray matter, we have the white matter, there's the pia mater, and here's subarachnoid space. This is subarachnoid space. Then arachnoid mater, and subarachnoid hemorrhages sometimes occur, so it would occur in this area. And then we got pia, no, that's dura mater. And right here's the epidural space. So in this space, we'll have epidural hemorrhages. Yep. And where do we have flexi cerebri? Well, don't really need to know that. And we mentioned the gray and white matter, subarachnoid space matters, pia mater matters, arachnoid granulation, dura skull. Alright. And then the next one, meninges. Again, have the gray, no, that's the cortex, gray matter. So we got pia mater, arachnoid matter, meningeal dura, skull, and then scalp. No one really is interested in peritoneum, perosteum. So, and another similar diagram. Alright, so now we will move to the hematomas. So epidural hematoma can occur in patients who were, for example, an automobile accident, and they hit their temple where the bone is thinnest, and also there's a little spot, some kind of foramen ovale, that has artery running through. And when the bone in the temporal region breaks, it punctures that artery, and artery leaks into the side of the skull, pushes on the brain, and on the CT scan you will be able to observe a lens-shaped hematoma. So it occurs above the dura. So in this diagram I have, I think this is the pia mater. Okay. maybe this is the brain, this is the pia mater, this is arachnoid mater, this is the dura mater. So it's above the dura, epidural. Epidural space, accumulation of blood between the skull and dura mater. Epidural space, temporal region. The hematoma will look on the CT scan as biconvex. Mechanism break in the temporal bone and lacrimation of the middle meningeal artery. Signs and symptoms: headache, nausea, focal neural symptoms. Oh, one interesting sign and symptom with epidural hematomas is that patient will first black out, but then they will regain consciousness. After they regain consciousness, their vital signs are okay, even good. And then after a while, they came home, they went to bed, they will have rapid decline in both their vital signs and level of consciousness, and they might get into coma. Not good. So, and this period right here, when they regain consciousness and their vital signs okay, is called lucid period. So also with them we can see with this type of injuries, one of the symptoms may be the cranial nerve number 3 will be affected, and it affects the eye movement, and they can get that cerebral cranial nerve number 3 palsy, where the eye moves downwards and outwards. And pupil will be dilated. So if this is the nose and this is the eye, the pupil will move outwards, downwards. It will be blown, and that would be the eye. So they will lose consciousness, as I said, blackout, then they will wake up, have normal vital signs, lucid period, and then rapid decline and comatose. So again, pupillar abnormalities will be seen. Okay, diagnosis: CT scan of the head. Ligament line. Treatment: craniectomy, drain hematoma, drill, evacuate hematoma due to increased intracranial pressure, mannitol, decrease cerebral edema, elevate head, have a shunt, hyperventilate, monitor for signs and symptoms of case, intracranial pressure and neurologic deterioration, and you can add sedate the patient. Okay, next one, subdural hematoma. So that's purple below the purple line. Fatal if acute. Subdural space. So I think this one usually occurs in elderly. Let's see where it is. Oh, there it is. Subdural. So this one usually occurs elderly. When they age, their brain shrinks, and because this area shrinks, because this area shrinks, this area still has more open space here, especially here, between the dura mater and the brain. More likely, the brain has more choices to move in the skull, and also those artery blood vessels in these areas, they will rupture. When they rupture, this is what occurs, hematoma, and they also bleed, and so they start push on the brain. When they push on the brain shifts to one side, and if it moved 5 millimeters from the midline, then some drastic interventions are necessary, such as craniectomy or increase in drainage of cerebrospinal fluid. So space, subdural space, acute. So when there's a vehicle trauma, blunt trauma to the skull, falls. In older adult patients, shift can tear bridging veins because their bone is atrophic. Can tear bridging veins between those spaces where the dura mater. It says subdural hematoma. So dura and arachnoid. Alright. There we go. Arachnoid. Come on. So arachnoid space right here, and bridging veins are in between. When they tear, the bleeding occurs. So signs and symptoms: increased blood pressure, decreased heart rate, confusion, and no lucid interval. Okay. Diagnosis: CT scan. Crescent concave hematoma can cross suture line. Treatment: midline shift more 5 millimeters from the midline. Evacuate hematoma. Burr a hole. Craniectomy. Postoperative complications: brain swelling, increased intracranial pressure, and seizures. Assessment: clear cerebrospinal fluid with glucose. Oh, that's next thing. Okay. So subarachnoid hematoma. Those occur underneath the arachnoid layer. Subarachnoid hematoma occur under arachnoid layer. So they can occur right over here where the circle of Willis is, and these veins or arteries, they rupture. Up, there we go. And they bleed and cause pressure on the brain. Mechanism: berry aneurysm rupture and anterior communicating arteries rupture. Signs and symptoms: well, these people who experience excruciating headache, the worst headache they ever felt, and it's also can be called as thunderclap. Thunderclap. They will have nausea, vomiting, focal symptoms, neck stiffness, photophobia, and delirium. Neck stiffness, it is similar to that chwastic. No, there's two signs for meningitis. meningitis, such as head stiffness, and when you raise their leg, they experience some discomfort in their back. So diagnosis, again, the CT scan, then vessel angiography. If negative, if CT scan is negative, then lumbar puncture, and then xanthochromia. Check the red blood cells. So increased cerebrospinal pressure, retinal hemorrhage, ophthalmoscope, Torsades syndrome. Torsades syndrome. So you can assess for cerebral hematoma with ophthalmoscope. So treatment, bed rest, stool softeners, decrease blood pressure gradually, labetalol, nicardipine, nimodipine, cooling or clipping. Of that area. So intracranial hematomas, well, that's what I think are caused by hypertension and old age. Those little blood vessels in the brain, they will rupture. These little blood vessels will rupture, and then these blood vessels around the latiform nucleus, and this one's thalamo-geniculate arteries will rupture, and paramedian pontine branches will rupture. Little small blood vessels from increased intracranial pressure or amyloidosis, and they will increase the intracranial pressure. So again, places: thalamus, basal ganglia, pons, cerebellum. Reason: the increased intracranial pressure or amyloidosis. Signs and symptoms: headache, nausea, vomiting, hemiparesis, hemiplegia, decreased level of consciousness, and diagnosis is with the CT of the head. Do not do lumbar puncture, will herniate the brain in case of the intracranial hematomas. Treatment: increased intracranial pressure is treated with mannitol. If mass effect evident, evacuate hematoma. So this is as much as I have for hematomas, and next I will be talking about treating intracranial pressure.